Good evening, colleagues. I'm Dr. Arvind. On behalf of MCure team, I would like to welcome each one of you in Eminent session. At the outset, I take this opportunity to wish you and your family a very happy new year. With Eminent, now we have changed our page from 2020 to 2021. Topic for today's academic discussion is a masterclass in ABO incompatible kidney transplantation, a very refined and unique topic, I must say. We have put together a very comprehensive agenda. As you can see that we have none other than Dr. Professor Vinay Sakuja sir as our moderator, and then very esteemed faculty followed by the panel discussion. Without a further ado, now I invite our moderator and chairperson, Dr. Professor Vinay Sakuja sir. He doesn't need any introduction. He's the Director Nephrology and Transplant Medicine at Max Super Specialty Hospital. And thank you so much, sir, for your time today and joining us. And now I hand over session to you. Welcome to Eminent 2021.
Thank you, Dr. Arvind. It gives me great pleasure to first introduce our two speakers for today. Both the speakers are well-known alumni of the nephrology department of the Postgraduate Institute of Medical Education and Research, Chandigarh. The first speaker will be Dr. Raja Ramachandran, who's an assistant professor in the Department of Nephrology, PGI, Chandigarh, right now, having continued there as a faculty member after his post-graduation. And he'll be speaking on ABO incompatible kidney transplantation. The second speaker is Dr. T. Muthukumar, who's currently an associate professor at the Weill Cornell Medical College in New York. And he was also, several years ago, one of our very good students at PGI Chandigarh. It's great to renew our contacts with him. His subject will be de novo donor-specific antibodies after kidney transplantation. And following their presentations, we will have enough time for discussion. And during that time, we have two panelists who are very eminent and highly experienced nephrologists. We have General P.P. Verma, also an alumnus of PGI Chandigarh, who's now working as the head of nephrology at the Primus Hospital, New Delhi. And we have Professor Amit Gupta, who recently retired as head of nephrology from STPGI Lucknow and is now a senior consultant in nephrology at Apollo Medics in Lucknow itself. So we'll be looking forward to your contributions to this session. So I will now request Dr. Raja Ramachandran to take over and start his presentation on ABO incompatible kidney transplantation. Dr. Raja, please.
Thank you, sir. And just give me a minute. I'm just sharing my slides.
Yes.
Good evening, all. Thank you for the warm introduction, sir. And is my slides visible to you all?
Yes.
Thank you. Sir, it's a privilege to be introduced by you. And I also welcome my co-speaker, Dr. Muthukumar, for the session. So I would be going straight into the topic. So the question pertinent to the topic are, when do we do a renal transplant, that is an ABO incompatible renal transplant? How do we determine the isoagglutinin or the antibodies, tube or the gel method? How do we reduce the antibodies? Do we do a plasma exchange or plasmapheresis, double filtration plasmapheresis, or a glycosorb column? And what is the role of rituximab as a desensitization protocol? And when do we proceed with a transplant? At what titer? And a general note on the induction, maintenance immunosuppression, and antibody monitoring post-transplant. So, what are the objectives of renal transplant? The objective of a renal transplant is to ensure the patient doesn't need any form of kidney replacement therapy for rest of his life. Also, we need to keep in mind the lifespan of the patient shouldn't be shortened. What have we achieved over the years is the incidence of steroid sensitive rejections have been significantly reduced. However, the incidence of steroid resistant rejection continues to remain the same mostly. Why do we do an ABO incompatible transplant? Tissue and blood incompatibility have been traditionally an absolute contraindications to renal transplantation. This was based on historically poor outcomes when renal transplantation was attempted across the ABO barrier or when the patients were sensitized to HLA. In addition, improvement in the results using disease donor allograft limited the enthusiasm of an ABO incompatible transplantation in late 80s. However, a decline in the availability of disease donor kidneys in certain countries like Japan because of the longevity have again renewed the enthusiasm for an ABO incompatible transplant. Plus the burgeoning of CKD, ESKD cases and limited donors, Indians have also adapted to the ABO incompatible transplant. Cost is certainly a feature with an ABO incompatible transplant. Rejection rates are clearly higher as compared to an ABO compatible transplant. Factoring both, kidney pair donation is certainly more scientific, cost-effective strategies, fairer outcome to engage ESKD patients going or requiring a renal transplant. ABO blood group consists of four common types: A, B, AB, and O, with B and O being the most frequent in India. It is, I think, A and O in the Western world. The antigen expressed on the erythrocyte, lymphocyte, platelets, and also on the epithelial and endothelial cells. Formation of blood group antibodies occurs against those antigens which are not native to the host. Thus, antibodies to both A and B are found in patients who have an O blood group, and patients who have an AB blood group do not have any antibodies. Given the distribution of blood group antigens and the disease donor program at least PGI Chandigarh, the waiting list for an O blood group is exceedingly high. In addition, the O blood group patients also tend to have a higher isoglutamine antibody compared to those with A and B. That is, patients of O blood group have higher anti-A antibody than patients of B blood group and have high anti-B antibodies compared to patients of A blood group. Also, the blood group A can be divided as blood group A1 or A2, or what some people say is A1 and non-A1. The antigenic expression of non-A1 is quantitatively and qualitatively less as compared to A1, and the overall immunogenic risk of non-A1 is less compared to A1 blood group. Hence, if you factor the overall immunogenicity, it is basically an A1 donor would be highly immunogenic, followed by B, followed by A2 or non-A1. Given the lower immunogenic with A2 blood grouping, the donor A2 donor kidneys from A2 can generally be successfully transplanted into recipients with low pre-transplant anti-A titers without use of any desensitization. 80 to 85% of A blood group are A1 and non-A1 comprises of 15 to 20% of them. It was initially reported that an higher antibody titer predisposes to an increased risk of antibody-mediated rejection. It is unclear whether an elevated baseline antibodies predisposes to longer, poorer outcome given the initial success through desensitization. There is a marked difference also between the reporting of ABO titers between various institutions, also within the same institution depending upon the type of. Historically, tube technique or tube dilution method has been the most commonly used. Even in PGI till recently we were using the tube dilution method. Tube dilution method estimates IgM antibody and total antibodies, and then you can deduct and say that IgM and IgG antibodies. In addition, there is an observer bias or observer variation with the tube dilution methods. Thus, a titer of 1:32 may be somewhere in between 1:16 and 1:64. In recent years, the tube dilution has been overtaken by the gel agglutination test, which is sensitive, has good reproducibility, quantitative, easy to perform, and less time consuming. Knowing the method of estimation is important as titers differs based on the methodology. Evidence also demonstrate that the gel column agglutination has got a better reproducibility even among different institutions. So the Indian Working Group recommendation states that the gel column agglutination test is recommended as the method of choice for antibody assessment. The tube method is an acceptable alternative. The Indian Working Group recommendation was published in the year 2019 in the Indian Journal of Organ Transplantation. The next is, what is the target pre-transplantation? That is, what should be the antibody titer just prior to transplantation? Both IgG and IgM antibodies are present in circulation in an ABO incompatible recipient. However, IgG is more relevant to clinical outcome as compared to IgM antibodies because IgM antibodies are confined to the vascular spaces and are easily removed with any sort of desensitization. Higher pre-transplant IgG titers are associated with lower rates of graft survival and increased rates of acute rejection and also chronic rejection. The British Transplant Society guidelines recommends a baseline titer of less than 1:8 prior to renal transplantation. Evidence from Japan suggests that some investigators have gone on to perform a renal transplantation even with a titer of 1:128. The risk of rejection is high when you go and transplant at that kind of titers. Hence, the current consensus is to achieve a titer of less than or equal to 1:8 by a gel agglutination method. The Indian Working Group recommendation states that the pre-transplant IgG antibody should be less than or equal to 1:16, which is more liberal, and it can be taken as a cutoff to go for ABO incompatible transplant. The outcome of an ABO incompatible transplant depends on multiple factors, and therefore the patient and the caregivers needs to be counseled and educated that the titers are not alone the sole factor in determining outcome. See, the displayed study is one of an old study which was published in the year 2000 in the Journal of Transplantation. And this study is from Japan, where 67 patients underwent ABO incompatible transplant in between 1989 and 1995. 61 out of the 67 recipients were included for an analysis. The graft survival rate at 1 year, 5 year, and 8 year in patients with a titer of less than or equal to 1 is to 16 was 81, 67, and 67% at 1, 5, and 8 years respectively. And those with a titer of 1 is to 32 to 64 surprisingly had a better outcome, that is 94, 91, and 80% at 1, 5, and 8 years respectively. There was no difference in the outcome in between patients who had a titer of 1 is to 16 and 1 is to 32 to 64. However, in patients who had a titer of greater than or equal to 1 is to 128, had a 1 year survival, 5 year survival, and 8 year survival of 43, 29%, and 29% respectively. So the conclusion was preoperative maximum anti-A, anti-B IgG titers correlated with long-term graft survival in ABO incompatible living transplantation. So the antibody removal strategies. So this is the heart of the lecture. The reduction of the circulating anti-A or anti-B antibodies to pre-designated targets, that is 1 is to 8, is a key component of an ABO desensitization protocol. The two most common methods for desensitization are immunoadsorption or plasma exchange. Though plasma exchange and immunoadsorption are commonly employed for ABO incompatible transplant, there is no high quality evidence in the form of randomized trial to actually support their use. The outcomes are comparable, including the long-term outcomes as per the meta-analysis. The choice of technique is related to the availability, cost, comfort of the technique. Plasmapheresis prior to an ABO incompatible transplant is associated with increased bleeding risk during surgery. There can be oozing, venous oozing. Selection of the immunoadsorption is the method of choice for lowering the antibodies, but is expensive. Immunoadsorption is cost effective when you require more than 4 plasma exchange prior to transplant, that is in patients who have an antibody titer of more than 1 is to 128. Plasma exchange can be just done in the form of simple plasma exchange or a double filtration plasma exchange, which I would be dealing later. The frequency of plasma exchange should be individualized based on the titers. Regarding the use of plasma in plasma exchange, those patients who require more than 4 plasma exchange or those with bleeding diastases would require flush frozen plasma. In that case, the priority is to give an AB blood group plasma followed by a donor blood group plasma. Immunoadsorption columns are traditionally not recommended for reuse. However, because of various factors, we have been reusing the columns, and there have been multiple reports of how well it can be reused. And the traditional methods of reuse are saline flushing followed by ETO sterilization. The next is double filtration plasma exchange. Double filtration plasma exchange is a semi-selective blood purification technique, which is actually an extension of the plasma exchange. In DFPP, you have two types of filters. The first filter is a plasma separator, and the second is a plasma component separator. The blood is passed through a plasma separator. The plasma separator separates the plasma from the blood cells, and the blood cells are passed to the body. The plasma is further processed to a second filter which has got large and which has got pores which segregates larger and small molecular components by a plasma component separator. The large molecular weight component and including pathogenic substances can be disregarded, and the smaller molecular weight substances like albumin can be returned to the patients. The advantage of a double filtration plasma exchange is the volume of replacement fluid is significantly low for a unit of immunoglobulin removed as compared to a simple plasmapheresis. The The slide depicts the number of sessions of plasmapheresis required for a fruitful transplant with a target of at least 1:16. This is from the John Hopkins experience. All the patients with a titer of 1:16 or below received 2 plasma exchange prior to transplant. A greater number of post-transplant treatments was delivered to patients who had high titers prior to desensitization or had antibody rebound post-surgery or had antibody-mediated reduction. So if you see, if the pre-transplant antibody titer is about 16 to 32, you would require 3 sessions of plasma exchange. If it is 64, you would require 4 sessions. If it is about 128, you would require 5 to 6. If it is about 512, you will require 9 to 10. And about more than 512, you will require more than 10 sessions. This is sort of a thumb rule. I don't think, it's biology. So it's not that every patient would, adhere to what is being displayed in this slide. And also 2 points that one need to factor in with respect to the titers and the number of sessions of plasma exchange is these are all these antibody assessment by tube methods, and they were just simple plasma exchange and not DFVP. The number of sessions wouldn't be the same if you are using a gel-based technique for assessment of antibody and a double filtration plasma exchange. So the next is on the glycosop column. There are other columns also which are available, but the one that is recommended by the most is the glycosop column. Glycosop column in the first treatment reduces the IgG by 56% and IgM by about 81%. Multiple immunoadsorption treatments may become necessary before the patient gets to the baseline titer of less than or equal to 1:8. A study reported that there may be 7 sessions of immunoadsorption that is required for a titer of about 1024. An important advantage of using an immunoadsorption technique is it requires no replacement fluid and there is no risk of hypotension as compared to a plasma exchange. The major downside of immunoadsorption is the cost, which makes it less attractive in an Indian scenario. However, if one requires more than 4 sessions of plasma exchange, the glycosorb or the immunoadsorption column may also prove cost effective. As stated in the previous slide, I would again state the reuse of immunoadsorption column is not recommended. However, it is practiced, and it is simple saline flush post immunoadsorption followed by an ETO sterilization and storing it at 2 to 8 degrees in a dark place. So this is the Indian Working Group guidelines of antibody removal or preconditioning protocol. The selection method should be decided by the availability, the cost, and the experience of the center. Immunoadsorption is the method of choice for lowering antibody titers, but is expensive. Immunoadsorption is cost effective when you require more than 4 sessions of plasma exchange or when an antibody titer is more than 1:128. Plasmapheresis may be performed if immunoadsorption and double filtration plasma exchanges are not possible. The frequency of plasmapheresis should be individualized based on titers. In double filtration plasmapheresis, crystalloids with or without albumin should be used as replacement. AB positive plasma followed by donor plasma should be considered in case of coagulopathy or if the plasmapheresis session is more than 4. And immunoadsorption columns may be reused, and saline washes followed by ETO sterilization and storing in dark is recommended by the Indian Working Group recommendation. So the next is the intravenous immunoglobulin. Intravenous immunoglobulin has been historically a part of an ABO incompatible or an anti-HLA desensitization protocol. However, the enthusiasm for intravenous immunoglobulin has declined over time because there could be presence of anti-A and anti-B antibodies as well in IV immunoglobulin. You can use IV immunoglobulin patients who are at high risk of infections. In such group, the Indian working group recommends that you could choose IV immunoglobulin which has got low antibody titers. I'm not very sure that most of the Indian companies come up with such sort of data. If you are using IVIG, it should be 100 ml per kg post plasma exchange. Suppose it's a 60 kg man, you could use one time, you could use one vial, that is 5 grams of IVIG. The next time you could use 2 vials
Results,
of
would it
IVIG.
show that the ferricidox
So
and the
this is the
flavibrom
Indian working
have
group
very
recommendation,
similar
which says
effect
you need not have
in
to
the change
routinely
in the
prescribe to
ferritin and the
IVIG.
changes in
Can be
cardiac to
restricted to
start?
patients with high risk.
Had a very
So
similar
the
effect in the
next important part is the rituximab, which along with immunoadsorption or plasma exchange is the heart of desensitization. Prior to rituximab, it has been splenectomy, and there is data to suggest that rituximab is superior to splenectomy, and also the splenectomy bears morbidity in a patient with ESKD. ABO desensitization protocols employ rituximab along with plasmapheresis and immunoadsorption. The dose and the time has been largely variable. People have used from 100 milligrams to about a gram of rituximab, and also the duration, right from day minus 30 to 1 day prior to transplant, people have used rituximab. The British Transplant Society recommends that you need to use rituximab. However, in the absence of specific data on dose and outcomes, there will be no specific dose that has been recommended. And there is a study by Jenberg et al. Who reported that similar outcomes at 3 years of an ABO incompatible transplant using immunoadsorption versus rituximab alone in ABO incompatible transplant. The Indian working group opined that rituximab could be used in low doses, that is 100 milligrams to 200 milligrams, approximately 2 weeks prior to transplant, because that is the time you would have an ultimate CD19 or B cell depletion. And you need to also keep in mind there is increased risk of infection when you use a combination of rituximab and ATG. That would be, you would be knocking both the T and the B lymphocyte, and that needs to be explained to the patients. The next is on induction and maintenance agents. Rituximab, as stated in the previous slide, rituximab along with ATG increases the risk of infections. Although a small studies have found no difference in the rate of infection, I believe in an Indian scenario, use of ATG and rituximab, there would be an heightened risk of infection. There have been no, head-on studies to suggest or to draw any suitable conclusions. Hence, a caution is expressed. Routine titer monitoring of all patients is controversial in the post-transplant period. However, post-transplant plasma exchange would need to be offered when there is a graft dysfunction with an antibody-mediated rejection, or there is an increase in 2 to 4 folds increase in the antibody titer if you are monitoring them. The maintenance immunosuppression has been steroid mycophenolate and CNIs, preferably tacrolimus, and CNIs and mycophenolate mofetil are started 7 to 14 days prior to plasma exchange or immunoadsorption. And the CMV and the cotrimoxazole prophylaxis is something that needs to be religiously followed in the patients. So the displayed study, I would be discussing, these are my last 3 slides. I will be discussing 2 meta-analysis. One, the first meta-analysis, which was published in the year 2018, is a report of 26 studies, which also includes 20 patients from India. The 26 studies included 1,300 odd patients, and they compared 1,300 incompatible patients to about 5,000 ABO compatible patients. And the follow-up was 37 months in the ABO incompatible group compared to 40 months in the ABO compatible group. So the recipients of ABO incompatible allografts were slightly older, and all the 26 studies reported the 1-year survival. There was no significant differences between ABO compatible and ABO incompatible transplant with respect to the uncensored graft survival at the first year. The combination of the data revealed that the survival, 1 year graft survival was 98% in the ABO compatible versus 96% in the ABO incompatible. The difference was statistically significant. However, the difference, I don't know how much would be, it would really translate to a clinical effect. The subgroup analysis dividing plasmapheresis and immunoadsorption also revealed that there was no difference in between the two subgroups. The graft survival at 3 years remained inferior. Again, the difference was only 2%. The highlight is the risk of rejections. In the ABO compatible transplant, the risk of rejection was only 2%, and the risk of rejection was 10%. That was 5 times higher in an ABO incompatible as compared to the ABO compatible group. So the summary is the summary of the study would be is the ABO incompatible kidney transplant recipients have good outcome with minimal differences from an ABO compatible transplant, however, with an increased risk of rejections. 2019, there was another meta-analysis with larger population, which was published in the Lancet. It included 7,000 odd patients who had undergone ABO incompatible renal transplant. Compared to an ABO compatible transplant, ABO incompatible transplant was associated with higher 1-year mortality with an odds ratio being 2.17. The mortality was also higher at 3 and 5 years and was statistically significant. The death-censored survival was also higher in the ABO. The death-censored survival was better in the ABO compatible as compared to an ABO incompatible transplant. The 5-year survival was comparable. 5-year death-censored survival was comparable between ABO compatible and an incompatible transplant. So the conclusion is, despite significant progress in desensitization over the last 10-15 years, the 1 and 3-year survival is poorer in ABO incompatible as compared to an ABO compatible transplants. So it wouldn't be really, practical to compare an ABO incompatible transplant to an ABO compatible transplant. It may be more practical to compare an ABO incompatible transplant to surviving on dialysis. So the present slide, is a summary of the ABO incompatible desensitization protocol. The protocol is more or less similar. However, there can be small differences between various centers. At PJ, we start with rituximab and mycophenolate mofetil maybe at day minus 22 of a tentative date of transplant, followed by tacrolimus introduction maybe around day minus 10 of transplant, then immunoadsorption or double filtration plasmapheresis or plasma exchange depending upon your availability and your experience, to be started about day minus 7 of tentative date of transplant. And once you get a titer to 1:4 to 1:8, you can go ahead with transplant with induction with ATG or besiliximab and continue TAC and mycophenolate mofetil and introduction of steroids. Then regarding the further post-transplant course is more or less same. Some units do follow rigorous monitoring of the titers in the post-transplant period, and if there is an increase, 2 to fold increase, they do introduce plasma exchange, and the plasma exchange is also introduced if there is evidence of antibody-mediated rejection. So, the last slide is on the salient histopathology of patients with ABO incompatible transplant. Up to 3/4 of the patients can have accommodation. Accommodation means there is presence of only, deposition of C4D without any morphology and suggestive of antibody-mediated rejection, which is exceedingly common. And the other feature which is common in patients of an ABO incompatible transplant as compared to an ABO compatible transplant is presence of thrombotic microangiopathy. Thrombotic microangiopathy is also reported in patients who have a titer which is undetectable. It could be very much possible that the current detection techniques is unable to detect those antibodies, and patients with TMA portend poor prognosis, just like other TMAs in. And so with this, I conclude my talk, and I would take questions after the completion of the sessions. Thank you.
Thank you very much, Dr. Raja, for the extraordinarily clarity of your talk and for covering the entire subject very well. Of course, I'm sure there are bound to be questions in the minds of those who are listening, and we'll take them up after Dr. Muthukumar's talk. I now request Dr. Muthukumar to take over and give his talk on the subject of de novo donor-specific antibodies following kidney transplantation. Dr. Muthukumar, please.
Good evening, everyone. Are you able to hear me? Is my slide visible?
Yes, fine.
And the pointer?
Yes. You can see the pointer. Yes.
Okay. Good evening, everyone. It's an honor for me to present here today. My sincere thanks to Dr. Sakuja for this opportunity. Now, the topic for my presentation today is going to be de novo donor-specific antibodies after kidney transplantation. Now, there are two terms here. One is de novo and the other one is donor-specific antibodies.
Muthu sir, can you please make your slide on slideshow mode?
Is it fine?
Yes.
Yeah,
fine.
Thank you, sir.
Okay, thank you. So there are two terms here. One is de novo, the other is donor-specific antibodies. Now, let's dissect them a little. What is a DSA? Now, it's simple. DSA stands for donor-specific antibodies. Donor is a simple term. Specific is directed against the donor. But when we say donor-specific antibodies, what antibodies we are referring to? Now, the current technology, which is the commonly used Luminex platform, detects only IgG antibodies directed against donor HLA. So in a way, though we call it donor-specific antibodies, we are actually looking only at the IgG antibodies directed against donor HLA or an IgG anti-HLA antibodies. Obviously, there are other antibodies that can also be detrimental to the graft. So what about IgM anti-HLA antibodies? And what about non-HLA antibodies? So these are also important, and we'll go over them a little later after we finish the donor-specific antibodies that are basically IgG directed against HLA. Now, what is this Luminex platform? Now, when we say Luminex, it's a company's name, Luminex Corporation, and they have come up with what is similar to a flow cytometer. So it's actually a dual laser cytometer. There are two lasers that sort of interrogate the individual beads in the platform. So what are these beads? There are about 100 beads available for a given reaction. This is basically a multiplex test. The advantage is that in a simple single reaction, you are able to identify more than one or any number of antibodies that are in the serum. So there are two companies that produce these assays. One is LabScreen, which is the company is known as One Lambda. This was the one company that was originally started by Dr. Paul Terasaki. And the other one is LifeCore. Now, what these two companies do is to create a contingent of beads, plastic beads. Now, each bead has two different colors at different concentrations. And when you shine a laser, depending on the intensity of two different colors, you are able to identify the bead as, say, one bead is bead 21, another bead is bead 26, something like that. Now, when we say a single antigen bead, each bead is coated with one HLA antigen. So the advantage is if this entire 100 beads is incubated with serum and the appropriate anti-human antibodies are added to pick up this binding of HLA antibodies in the serum to these beads, then you can use these lasers to identify which bead we are talking about. And based on that, you're able to say in one reaction, there is this antibody at this much strength and another antibody at a different strength. So the multiplexing of the antibodies has revolutionized the way the way anti-HLA antibodies are tested, because you do not need a lot of serum. Just in a small amount of serum, every antibody that's present in the circulation can be identified. Now, when we say antibody, it's a little tricky. Now, this image here shows the presentation of a HLA class 1 or HLA class 2 on the cells. So you have, say this is a HLA class 1. There are three things here. One is the class 1 heavy chain, which has three domains, alpha 1, alpha 2, and alpha 3. The other one is the beta 2 microglobulin chain, and the third one is the peptide. So in a given cell, when an antigen is presented, you have all these three together that is being presented to the lymphocyte. Now, when the same situation, these three things, the heavy chain, the beta 2 microglobulin, and the peptide, when they are coated on the beads, because these are all synthetically derived, you cannot replicate this exact configuration on the beads. So that's why these beads are known as denatured, in a way that what they are identifying is sort of a synthetic HLA that is coated on these beads. So it can be denatured in the sense that all three can be there in a different configuration. Only the peptide and the heavy chain may be there. The heavy chain alone can be there, or the heavy chain and the light chain, and the beta 2 microglobulin without the peptide can be there. So it's important to understand that when we talk about antibody detection, it is not replicating the exact antigen that's present in the class 1 HLA that's present in all nucleated cells, and class 2 that is present in antigen presenting cells. Now again, the company has come up with three different types of beads. Now in US and mostly in our lab, what we use is a single antigen bead. So my rest of the talk will be focused on the single antigen bead. So what is single antigen bead? Now I said 100 beads here. Each bead is coated with one antigen. So for example, bead number 1 is coated with A1, for example. Bead number 2 can be A2 antigen, so on and so forth. So the advantage of this is that the relative antigen density is high and the resolution is high, meaning that at this time, based on the currently available techniques, the single antigen bead assay, or the SAB, is the most accurate way of determining the presence of anti-HLA antibodies. So this is a cartoon of single antigen bead. Single antigen bead assay. The green, this is the beads, and this is the antigen coated there. When serum is incubated, if you have the corresponding antibodies, these antibodies binds to this antigen present on the bead, and then you add a phycoerythrin conjugated GOAT IgG that goes and binds to the FC portion of this human H antibodies, and this is washed and read. So this is the simplest way in which a single antigen bead assay can be performed. Now let's go back a little. In what happens when an antigen and antibody binding happens? So this is the classical complement pathway. You have, let's say these are the endothelial cells. You have HLA antigens. The antibody binds. So once the antibody binds, you have the first initial protein component of the complement, which is the C1 complex or C1q, binding to this, and then the complement cascade is established, which results in the terminal membrane attack complex, which punctures hole in the cell membrane and kills the cell. So the current assay of single antigen beads can be modified. How do you modify? Now, all we are showing here is that there is an antigen coated on a plastic bead, there is an antibody, and both of them are binding. So does this automatically mean that complement will be fixed and eventually this will result in cell death? In other words, does every antibody that's present in the circulation is pathogenic? We do not know that. So for that, there are refinements to the conventional single antigen bead assay. And one refinement is the presence of the identifying whether this particular the HLA antibody that we are talking about, is it a complement fixing antibody or not? So how this is done? Again, this technique is the same, but the test can be modified so that the phycoerythrin anti-human antibodies can be used to identify whether C1q has bound to the antigen antibody. So in other words, instead of simply saying that there is an antibody, you can go to the next level and say that this antibody is not just any other antibody, it's an antibody that can bind C1q, which means that this antibody is there and it can potentially cause mischief by activating the classical component pathway and causing cell death. Now, again, in this testing process, there is something known as prozone effect, which is important to understand. Now, what is this prozone effect? Now, prozone effect results in a false negative test, meaning that the serum appears negative when it is tested undiluted. So you take a serum, send it to the laboratory asking that, can you please check whether there is donor-specific antibodies? The lab does the test and reports that the donor-specific antibody is negative. But in reality, it's a false negative test. Why is that? Because of two reasons. One is that what is known as a prozone effect, though it's erroneously called prozone effect, this terminology has stuck. What it means is that when complement system is getting activated, the C1q or the C3d can sort of bind to the antibodies with the result that the reporter antibody, the phycoerythrin conjugated GOAT anti-human antibody that's added to the system to find out whether an HLA antigen has been bound to an antibody is blocked. So when this blocking happens in an undiluted serum, typically in the laboratory, these are tested in undiluted or what is known as a neat serum, then this blockage results in a negative test. So there can be full of circulating antibodies in the system, but the report will be coming out as something that's negative. So for this, a couple of things can be done. One is to dilute the serum or treat it with EDTA, sort of which breaks down this and allows the PE conjugated antibody to bind to the system. So most of the labs in US currently routinely treat the serum with EDTA. So when the report comes, they say the serum has been treated with EDTA to make sure that the prozone effect has been taken care of. So how is the output of these antibodies reported? You would have heard of the term median fluorescent intensity. Now, in general, as physicians, we are used to think of as when we say output and cut point, when we do a test, we expect a result, and that result is a quantitative term. Check for creatinine. Creatinine is 1 milligram per deciliter. That's a quantitative term. We have in our mind a linear scale in which we think, okay, this patient's creatinine is 2 milligrams, which has gone up from 1 milligram, or the creatinine has dropped to 0.5, 0.8. It has gone down from 1 to 0.8. So whether it's blood pressure or creatinine or glucose or white count or hemoglobin, for any quantitative measurement, we have a linear scale that we sort of think. But unfortunately, the median fluorescent intensity or the output of the DSA measurement is not on a linear scale. In fact, it is no scale at all. MFI is not a strength. MFI is not a concentration. It's not a quantitative assessment and does not represent the concentration or the titer of the antibody. It simply beats relative fluorescence without reference to a standard. So this makes it obvious that it is very difficult. It's not that it cannot be done, but it is very difficult to standardize the MFA values across different labs or even across different beats or across different samples. But despite that, when we read papers, we will say that, okay, the lab says it's more than 500 or more than 1000 MFI. More than 1000 MFI is associated with something. So we try to use this as a quantitative measurement, but in reality, we need to understand that this is not a quantitative measurement. Again, the question that comes is AKI, let's say acute kidney injury, we can come up with a creatinine definition. Okay, creatinine has doubled, or come up with an absolute number. Creatinine more than 1.3 or 1.4 is called as acute kidney injury. Like that, our tendency is again to ask for a cut point and say that what is the MFI threshold above which it is positive. So this is in a way becomes sort of a philosophical question. When we say threshold, threshold for what? What do we want to achieve here? So the original thresholds that came was mostly to find out at what point of DSA determination by Luminex your flow or your CDC cross-match becomes positive. So one can say that I also want a threshold for saying, does this patient is an increased risk of a slow chronic antibody-mediated injury? Or are we talking about acute hyperacute rejection so that there is something that's going to happen on the table? The antibody titers are so high, much above my threshold, so that there is something that's going to, there will be an immediate hyperacute rejection. So the question here is, what is this MFI threshold for? So we need to be careful when interpreting a given lab's MFI threshold and ask the question, working closely with the lab, trying to find out what is meant by this threshold and based on what this threshold has been determined. Now let me spend a few minutes here. This is our tissue typing laboratories DSA report. Now let's focus here. This is the patient, this is the donor information, and this is how DSA is reported. The HLA for the patient, HLA for the donor, and the DSA is reported here. Now, where are these numbers coming? These numbers are coming from here, which is your single antigen bead assay. So as I told you, I'm focusing only on class 2 single antigen bead here. So as I told you, there are 100 beads. Let's say first bead is DR1, second bead is DR1. Again, it's a DR1, but it's a different antibody specificity. So these are the 100 beads that are available in the system. And when a serum is added, the machine does not know whether we are dealing with DSA or non-DSA. It simply provides an output for each bead, and this is the output for each bead or the MFA value. So this means for this patient is sensitized in the sense that this patient has multiple antibodies against HLA. Remember that unlike blood group antibodies, you do not have natural antibodies against HLA. Even that concept is changing a little, but for all practical purposes, let's assume that there is no natural antibody. If I am HLA-A2, if I'm blood group A, I have natural antibodies against blood group B. But if I'm HLA-A2, I don't have natural antibodies against other HLAs unless I'm sensitized. So this patient is sensitized, meaning that there are plenty of antibodies as shown here. Our lab cut point is 2000. So you will see here that IgG DSA greater than or equal to 2000 MFI deducted against donor HLA antigen. Now, how do we know this is donor? That's what this information is put here. So you look at the donor HLA and then the machine provides, okay, donor has HLA A1 and let's look at HLA. I'm not showing the class 1 here, but let's look at the HLA A1B and find out what the MFI is. The MFI is 448, so that number is given here. Now, why am I showing this information in this detail? It's because of this. You will see here that it's HLA DR52 is written as 10,000, but it's stuck and a number is written by hand that it is 1186. Now, is it a mistake? No. What happens is, let's look here. This is DR52. If you look DR52 here, there are 3 beads in the reaction. So each bead is providing an MFA value. The machine, the computer algorithm simply picks up the highest MFI value, which is 10,390, and puts it here. So what it means that DR52, I did a Luminex single antigen bead. In that reaction, there are 3 DR52 beads. The highest bead is 10,390, and that's what is given here. Now, this patient, the donor is DR52, but DR52 has several subtypes. Now, it so happened that this donor had a high resolution typing done. And if you see here, this donor's high resolution typing is for DR52. It's DR52 of B3 chain. You will see that the high resolution typing is 01. We'll come back in a little moment what is meant by this high resolution typing. So now, if you look at DRB3, so there are only, of the 3 beads for DR52, only 1 bead has this 01. So we are talking about this high resolution typing of 01 here, which is the next level after DR52. And of the 3 beads available here, you will find that only 1 bead is DR52 subtype 01. So in reality, though the superficial level typing for this patient is DR52, this patient's DR52 is further subdivided into DR52B311. So the antibody directed against that is simply 1186 and not 10,000 MFI. So that's why it's put here as 1186. So if you go by our threshold of 2000, this is not a positive antibody. I hope I have made this clear at this point. Now again, when I say it is not a positive antibody, we are not talking something like a tuberculous antigen. It's present or absent, nothing like that. It is not positive in the sense that, again, I asked the question in the previous slide, threshold for what? So one can say that this is not an positive antibody in the sense that you are not talking about a hyperacute rejection or a positive cross-match if this would have been happened in a pre-transplant scenario. But in a post-transplant, is this titer or this MFI value significant enough to cause a problem in the long term? Yes. So this is the major histocompatibility complex. So it's a gene cluster that's present in all jawed vertebrae. A, B, and DR is the commonly reported, where most polymorphisms are present, and it has strong association with graft outcome. But remember that it is not simply A, B, and DR alone. DP, DQ, and C also plays a major role. So though our focus is only on A, B, and DR. Now, I told high resolution typing and I told subtypes. What is this HLA nomenclature? So the current HLA nomenclature is written like this. We call this fields, and there are 4 fields here. Field 1, field 2, field 3, and field 4. Plus, after the end of field 4, you have a suffix which is a series of alphabets here. Now, the way serological typing is done, once upon a time, HLA was determined by serology. Just add, like your blood group typing, just add serum and cells and then see whether there is agglutination, and then you know that you're dealing with this particular antigen. So the serological typing is this field. The next level of typing goes to the second field, which is 101. I'll come back to that in a minute. Now, when we say serological typing, currently in the United States, all HLA laboratories are supposed to do a DNA-based assays for HLA and not serology. So when you use a DNA typing for HLA, we call a low resolution typing, a high resolution typing, and an allelic resolution. So what's meant by that? Low resolution DNA typing corresponds to the serologically defined types, which is your field 1 resolution. Now when you go back, this is the typical way HLA is reported. HLA A1, HLA A3, but this is not serology. This is serology equivalence, but this is all done by DNA typing. So in other words, every lab is supposed to do a low, at the minimum, to get license and to function, they need to do a low resolution DNA typing, which is equivalent to your serological typing. So this corresponds to serological typing. Now, field 2 is identification of an HLA allele that encodes the same protein sequence within the antigen binding site. So when you go to a high resolution typing, we define field 2. Here the example I have provided is 101, which means that HLA-A2 101 and HLA-A2 102 are different proteins but does not react with each other in serological test. In other words, when you do a serology, you cannot, if I am A2 101 and you are A2 102, simply by doing serology, you cannot differentiate between you and I. But when we do a molecular typing at a high resolution level, you are able to say, I am 02101 and you are 02102. Why is it important? Do we need this? Now, imagine a scenario where there is unlimited supply of organs. We don't care about all this. Simply HLA-A2, is it fine? Yes, there is an organ available, go ahead. But the problem happens is when you do a serological or a low resolution typing and simply call it HLA-02 and there is HLA antibody present, what are we going to do? We are going to say that this recipient and donor are not compatible. Because there is always a short supply of organs, you want to match for compatibility as much as possible. So we have gone to the next level and say that, okay, two people are having HLA-A2, but if one is 101 and another is 102, then if I don't have an antibody against 102, then I'm able to get that organ. So in other words, this resolution is important to further subtype the HLA so that to identify whether the antibody present is really directed against one particular type or the other particular type of this field 2. So we spoke about HLA, which is probably very simple. Now, if this is so simple, what about the other non-HLA or other minor histocompatibility antigens? Now, minor histocompatibility antigens are highly glycosylated MHC encoded molecules. You know that MHC class 1 related genes A and B are MICA A, MICA and MIC-B are important. There was a New England Journal paper several years ago that associated MIC-A and MIC-B with long-term graft function. This MIC proteins acts as a ligand for natural killer cells and CD8 positive cells. These are basically short peptides derived from processed polymorphic proteins and are expressed on multiple cell types in our body. Now, what about non-histocompatibility antigens? Endothelium serves as the major source of cocktail of antigens. Angiotensin receptor type 1 is an important non-histocompatibility antigen. Endothelin 1 type A receptor, vimentin, vascular basement membrane component perlecan are some of the non-histocompatibility endothelial antigens. Now, commercially available kits are, there are kits that are commercially available, but still there are only selective labs that does this non-histocompatibility antigens. Now, let's go a little deeper into this. When we say non-histocompatibility antigens, now I said HLA is more polymorphic. If you are donating kidney to me, your HLA and my HLA are different, so I can form antibody against you in the post-transplant situation, which is your post-transplant DSA. But your endothelial cell and my endothelial cell are more or less similar. So your angiotensin type 1 receptor and my angiotensin type 1 receptor are going to be the same. So when you say I am as a kidney recipient forming an antibody against vimentin or angiotensin type 1 receptor, are we saying I'm developing an autoimmune disease? Because more or less your and mine angiotensin receptor is similar. Now that's, as of now, we assume that this is all sort of a loss of tolerance, immunological tolerance and autoimmunity, meaning that I develop antibody against normal body components, which is angiotensin receptor type 1 or endothelin and so on and so forth. But is that real? Meaning that do we definitely know this is not alloimmunity? Because there is a lot of single nucleotide polymorphisms, is there a guarantee that my AT1 receptor and your AT1 receptor are not changing at an amino acid level? We do not know the details of that yet. A couple of years ago, we published a paper where we introduced a concept known as allogenomics. We did DNA sequencing. DNA sequencing looks at the entire DNA contingent But instead of focusing on the entire DNA, we looked at what is known as exome sequencing, or sequencing of the DNA that codes for protein. And then tried to find out in that whole DNA sequencing information, what are the amino acid mismatches between recipient and donor. An example is provided here. Now, lysine and lysine here is, let's say this is your angiotensin receptor situated on the cell surface. Now, lysine and lysine are same, but here there is a change in the amino acid. Now, this change in the amino acid is obviously can create an antibody response because there is a mismatch here at that particular level. So based on this type of amino acid mismatches across the entire contingent of protein coding DNA, we came up with a mismatch score, meaning that higher the score, more the amino acid mismatches. And then based on 3 different transplant cohort, we were able to show an inverse association between EGFR and this allogenomic score over a long term, meaning that if you have a high score, meaning that if you have plenty of mismatches across the amino acids between the donor and the recipient, you have an inferior graft outcome over the long term. So this is something to keep in mind, that non-histocompatibility antigens may not cause an acute problem, but over time, there is a problem. So we dissected the word donor-specific antibody, or this antibody, but what is de novo? It's a Latin term from the beginning, meaning that it happens after the transplant, based on at least what we want to know in a transplant scenario. But is that real? So let's go back to this again. Now, when I said 448 is the DSA here, or 2406 is the DSA here. Now, how are these studies done when somebody says de novo donor-specific antibodies? You look at the report, pre-transplant, what was the DSA? Positive, negative. Post-transplant, what is the DSA? Positive, negative. So if you go like that, remember that I told our lab cutoff is 2000. So somebody with a DSA, somebody with an MFI of 1531 or 1999 will be labeled as negative pre-transplant. And tomorrow after transplant, if this 1531 becomes 2005, or this 1999 becomes 2400, we are going to call it positive, and we are going to call it de novo, meaning that this happened after the transplant. So in a way, this is semantics, meaning that to say that there was completely absent antibody response before transplant, and this all happened completely new after transplant is a little challenging. But studies continue to go with the idea that there are preformed antibodies. At some point, you decide to do desensitization, and for several patients, you do not, say flow B positive. You simply go ahead, increase your steroid dose, increase your thymoglobulin, and then go ahead with the transplant. That is one group of individuals. And certain other group of individuals develop new antibodies post-transplant. This is the Alex Lupis Paris study from France in New England Journal 2013 that looked at this C1q antibodies. In that, you will see that de novo antibodies, C1q negative at C1q DSAs negative pre-transplant, but positive post-transplant has the worst outcome in terms of graft loss. This again has to be taken with a grain of salt. It's simply possible that somebody who has a pre-transplant antibodies, because you know that they have pre-transplant antibodies, you monitor them more carefully, and post-transplant, there may be a time delay. So because of that, this could have been simply a time effect rather than the property of the antibody that's causing this problem. So to summarize, so DSA is not, when a DSA is reported as absent in a post-transplant situation, remember that MFI value, what is meant by absent? MFI is a continuous scale. It's not a linear scale. So if a lab uses a dichotomous cut point, 2000 is negative, 2000 more than 2000 is positive, we need to be aware of that. Absent at the time of biopsy, but what about earlier? You do a biopsy today at that, thinking that there is something wrong, and that time it is absent, but what about earlier? Again, most of the labs focus on HLA-A, B, DR. What about others? As I said, DSA strength and rather than MFA value, and complement-mediated prozone effect and EDTA treatment, whether this has been done or not. think I'm running out of time, but let me finish in a couple of minutes. Now, obviously, this all takes to the next level that you need some molecular monitoring tools. Simply following creatinine post-transplant is not enough. There are several tools that are available in the market. This TrueGraph comes from whole blood mRNA. This is approved and it is commercially available. Plasma cell-free DNA, which is the commercial test mode. There are 3 companies providing this. And this is developed in our lab, in Dr. Sudhantran's lab, which is our urine cell-free, urine cell mRNA profile. And we are trying to use a home filter in which patient is able to get his own urine sample, isolate RNA, and send it to us. And we do the gene expression profile to see the gene expression is sort of molecular quiescence or molecular activity going on. And also in blood samples, you can look at CD4 positive T cell activity to see whether a CD4 cells are sort of a sleeping cells or an active cells. So there are several molecular monitoring tools that are in the market and further that are being developed. Now, finally, let there be de novo TSA. So what? Why do we care? So the problem is this. Now, over time, you will have a chronic endothelial injury, remodeling to the kidney, with the result that you develop transplant glomerulopathy. As you see here, this is the arrow points to the double contouring on the silver stain. And this you will see the MPGN-like picture or the sort of a proliferative GN-like picture. So what is this transplant glomerulopathy? As I said, you have an antibody that's binding to the antigen on the endothelial cell. It not only kills the cell at one level, but simply the binding of HLA antibody to HLA antigen activates the endothelial cell, which results in a lot of cytokines being produced, bringing in a lot of cellular infiltrates, macrophages, NK cells, and causing problems or an inflammatory state at the local level, which results in constant remodeling, which results in double contouring of glomerular basement membrane, change in architecture, proteinuria, fibrosis, gradual progression to end-stage kidney disease. This is a paper that we published. In fact, Pallavi is currently in Bangalore. She was our former fellow here. This was in Kidney International on 92 patients with transplant glomerulopathy. What is important here is, of these 92 patients, only 25% had a documented acute rejection episode. The remaining did not have a documented acute rejection episode. What does it mean? It's not that every antibody that's going to happen after transplant will result in acute rejection. At least when you result in acute rejection, you have an idea that, okay, I have identified a problem. But instead, if there is a slow, chronic, ongoing injury that happened in 75% of these patients, it will end up in transplant glomerulopathy. So it's important to keep in mind that there is the most common way in which de novo donor-specific antibody manifests is a slow, chronic, ongoing injury, which results in graft loss over a long term. So this is my last slide. So we discussed about donor-specific antibodies. We discussed about what are the consequences of donor-specific antibodies. I'm not going into the treatment. We can discuss that during the panel discussion a little more. But after all this, it's so depressing that you have a patient, you have transplanted, but these antibodies come, you're not able to do a lot. So where are we going in the future? Now, again, we are in an exciting time where there is a lot of molecular monitoring and molecular tools that are available. One such revolutionary technique is a single-cell RNA sequencing. Now, sequencing is a technique to determine the order of nucleotides in a segment of DNA and RNA. So by doing a transcriptome sequencing, you can look at the entire mRNA or a microRNA contingent of a given sample. Now, single-cell RNA sequencing allows comparison of transcriptome of an individual cell. Now, this is a recent review that we wrote in Current Opinion of Organ Transplantation, published recently. So what it does is you take a kidney biopsy sample, dissociate into different single cell suspension, add colored beads. Each bead will capture the mRNAs that are present in each cell. And then after sequencing, you will do an analysis which basically separates out the cell. So you have this colored here. Each color represents a cell. So now you are able to talk, or you are able to identify a single cell, what is the transcriptome profile, and you start separating out those cells as, okay, this is your endothelial cell, this is your proximal tubule, this is your NK cell, this is your monocyte cell. So what? We can go to the next level to find out each cell, what are they trying to do. One example, let me show here. Now, this is a transplant patient who had a biopsy, who had an acute antibody-mediated rejection, treated completely. Creatinine came back to normal, no proteinuria. 9 months later, you do a surveillance biopsy, and that surveillance biopsy shows some cells here and there, but otherwise everything is fine, no fibrosis. But if you look at the endothelial cells, these are all the 4 different types of endothelial cells, you will see that one type of endothelial cells is producing some cytokines, CXCL9, CXCL10, or CXCL11. These are all called interferon gamma inducible proteins. These chemokines are attracted to T cells. So in other words, 9 months after successful treatment of an antibody-mediated rejection, successful by our conventional terminology, somebody's endothelial cells in the kidney is still producing cytokines that are attracting the T cells. So this provides a rationale of why these patients should be followed, treated, and provides a mechanistic basis of why an episode of antibody-mediated rejection creates problem over the long term, though we may think that creatinine is fine, biopsy is fine, so the patient is completely improved. So these are certain techniques that are available currently. A lot of research is going on here, and in future, hopefully, we will be able to better understand the mechanistic aspects of what these de novo donor-specific antibodies are doing and how long-term graft dysfunction can be prevented. Let me stop here.
Thank you very much, Dr. Muthukumar. As all the listeners would have realized, this was a far more complicated subject, and I'm grateful to Dr. Muthukumar for having simplified it for the sake of our understanding as much as was possible. Of course, whatever doubts that you still have left in your minds will be sorted out once we have the discussion on both these topics. So now we can go on to the discussion, and I would now invite my panelists, General P.P. Verma and Dr. Amit Gupta, to present their views, to ask questions from both speakers, or to give comments. So both of them are now welcome to participate in the discussion so that we proceed further. We have enough time for this discussion. So General P.P. Verma, would you like to start?
Yeah. Thank you very much, Professor Sukuja. And as you rightly said, there have been 2 masterly lectures. Since Dr. Muthu finished last, I will just start the question from him. Going practically, we know that almost 15 to 30% of the patients develop donor-specific antibodies after transplant. You have given the concept that it is a continuum process, that possibly prior to transplant, he may be having whatever MFI which has increased. Now, do you have any protocol of monitoring the de novo antibodies post-transplant? Because the people who are going to develop, as I understand, that people who have got more HLA mismatches are people who are not getting adequate immunosuppression. They are the people who are going to develop de novo antibodies. Do you recommend any particular protocol that after transplantation, that if there was a lot of HLA mismatches, maybe every 3 months or 6 months or 1 year, we should check for the DSAs?
Yes, sir. That's a great question. Now, let me clarify that it shouldn't be viewed as all. There is no donors. There is no de novo antibodies at all. Everything is pre-transplant. No, it's not like that. There is de novo antibodies, But what I'm saying is, beyond the point, we need to be careful that whether was this a low level antibody that was present pre-transplant that is sort of memory response and coming back after the transplant, or is it a new antibody? In a way, do we really care? Probably not. As long as we went ahead with the transplant because your cross match was fine, and then there is a donor specific antibody. Now, the question is, how frequently should I look for this and what am I going to do? Now, again, this comes back to the cost. I'm well aware that these are all expensive tests back to do this back home. Here, for us, cost is not an issue, so we try to do it at least from us. We do single antigen bead assays for the first 2 years, at least every 3 months, and or when there is an event, say when there is a BK virus infection and we reduce the immunosuppression, or for whatever reason, like severe diarrhea or bone marrow suppression, the patient's cell set is reduced, or the patient was non-adherent for a brief period. When we say non-adherence, sometimes here what happens is because of insurance issues to get drugs, and when there is a delay, it is not non-adherence in the classical term, but if I'm asked to take 2 tablets of tacrolimus in the morning and 2 in the evening, I have short supply, I will go on 1 and 1 for some time. So the sort of lowish immunosuppression is the one that precipitates or activates the system, breaks the immunological sort of a prop tolerance that's there and brings up these antibodies. Now, repeated studies have established that non-adherence and reduced immunosuppression are the major reasons why donor-specific antibodies are coming up.
Mm-hmm.
So it's not fair to blame the patient for reduced immunosuppression. Sometimes we do it simply because there is an active infection or because the patient is not able to tolerate, but we need to keep in mind that these are the situations when donor-specific antibodies are coming up. So our protocol is every 3 months.
Now, are you going further down? Like if you are doing the DSAs, we know that C1q binding is bad, or we say that IgG3 is bad, or we say C3D or 4D is bad. Are you subtyping it also?
No. So when you say are you subtyping, there are 2 major subtypings that can be done. One is, as you pointed out, G3 and find out the IgG subtype, G3 and G4, or you can do C1q. C1q itself is controversial, whether C1q is a real thing that needs to be done, or it's simply a surrogate of a high MFI donor-specific antibodies. So most of the labs have not yet gone to do C1q or IgG subtyping as a routine. What we do is when we say that we pick up DSA at a low, let's say that somebody has no DSA at all, and when I do a 3 months DSA, it's showing up like 2,200, 2,400 like that. We do not do anything. We simply increase the immunosuppression. If the patient is on 500 milligram twice a day of CellCept, we increase it to 1,000 twice a day. Or if there is 1,000 twice a day, make sure that their adherence is not a problem. Increase the tacrolimus a little and follow the DSA again. Now, the moment it reaches around, it's our own cut point. Again, this when I say some cut points, I made it clear that cut points are cut points. We need to talk to the tissue typing lab, and we need to come up with our own cut points. But at least when our cut point is around 6,000, 8,000 like that, we tend to do a protocol biopsies and see whether there is any microvascular inflammation. When you have microvascular inflammation, so a situation that I'm talking here is creatinine is completely normal, DSA is gradually increasing, and it's around 6,000, 8,000 like that. And at that context, no microalbuminuria in the routine lab analysis. Do surveillance biopsy, and surveillance biopsy shows microvascular inflammation as characterized by a glomerular G2, G3 or a PTC2, PTC3. We don't do a full-fledged AMR treatment, but we treat with IVIG and solumetrol pulse. And whether that's helpful or not is difficult to say because we don't have any randomized studies. But when we don't do any of this and simply follow these patients, nearly 30% of them between 3 months protocol biopsy and 12 months protocol biopsy develop transplant glomerulopathy and fibrosis.
Any shortcome? Because what you are trying to say that every 3 months you are trying to do the DSAs, even if patient has got normal creatinine, normal graft function. Now, if you are trying to pick up that DSA is gradually rising, that is the time you are resorting to protocol biopsy. And even if the graft function is appearing normal, we treat this subclinical or whatever rejection, what is occurring, what do you say, MVI, that there is a microvascular injury, or you are trying to treat that. Isn't the product? So that is short of doing DSA every 3 months. Is there any other shortcut?
Short of doing DSA, is there any other shortcut? That's why I provided this molecular monitoring tools. Now, as of now, the shortcut is, okay, DSA is extremely expensive. I cannot do it. What should I do? Protocol biopsies. Now, protocol biopsies to see any microvascular inflammation. Which patient do I do protocol biopsies? Let's say that somebody is clean immunologically to start with. There is no flow, assuming that flow has been done and an initial DSA has been done, clean, and that is a male patient. There is no chances of a sort of a pre-sensitization. So those patients, one may take the view that I'm not going to do any DSA in this patient. I'm not even going to do protocol biopsies because I'm not expecting anything to happen here. He's well compliant. He's maintaining his immunosuppression, full dose, nothing has happened. But you have a scenario. So when you say HLA mismatch is correct. But in the current era of calcineurin inhibitors, as long as you are maintaining a good level of calcineurin inhibitors and the patient is compliant with all the drugs and there was no reason the drug level was reduced, I don't think HLA mismatch alone is a major issue that you form de novo antibodies post-transplant. But if you can identify center-specific, our own high-risk patients who, say, for example, in our center, we say Black patients or anybody who had multiple sensitizations before, they may not be able to pick up by DSA at the time, or like I said, low level, like 1,000, 1,500, like that. So we are able to separate them into somebody clean, who are not expected to develop any immunological issues, or somebody who are expected to have a high immunological risk. So if you separate them into these two, even without doing a DSA, you can target on this group that is high immunological risk, either by doing protocol biopsies, or if this molecular monitoring tools becomes more cheaper as time goes on, like your AlloSure, which is your cell-free DNA, or your urinary mRNA profile, then you can follow this. And the moment there is an issue there, you can go ahead, either decide to treat it or do a biopsy and treat it.
I'll ask one question now from Dr. Raja. Again, as usual, wonderful talk. What is more important, you feel? Is it logically, is it the removal of antibodies or the stopping the formation of antibodies? Logically, I think you will agree, stopping the formation of antibodies is a more important component. How early the immunosuppression should be started? 1 week, 2 weeks, 3 weeks? Because we have to prevent the formation of antibodies. And a corollary to that, like you mentioned, the John Hopkins trial or Montgomery's trial studies, where they have not given rituximab at all. And their result at 1 year, 3 year, 5 year, the results are identical. So the Indian Society of Transplantation, where you are also one of the co-authors, have recommended the use of rituximab. But do you feel we can starting immunosuppression early, 2 weeks, 3 weeks early, and we can dispense with rituximab at all?
Thank you, sir. It's a very good question. I would confirm the questions again. One is whether the formation or stopping the formation or removal of the antibody is the key for a successful ABO incompatible transplant. The second one is when do we start the immunosuppression in these patients? Sir, to the first question, historically, an ABO incompatible transplant started with splenectomy as one of the desensitization protocol, along with plasmapheresis. So splenectomy essentially means, retarding the formation of antibodies. So none of them have been tried discreetly, but of late there are evidences where people have tried plasma exchange alone with ATG induction, and they have told that you could do transplant with basiliximab or ATG along with plasma exchange alone without need of rituximab. But yes, the shortcomings are these are not randomized trials, And there is only one trial which is compared immunoadsorption with rituximab. I did mention that. So that study says that, immunoadsorption and use of rituximab both are good with respect to, the outcome of the patients. So the bottom line as of now, I think the key is, stopping the formation, along with that removal. You target stopping first. How do you target stopping first? First, you give rituximab, stop the formation of antibodies, wait for 2 weeks, and then, start the desensitization process. It could be a plasma exchange, double filtration plasma exchange, or an immunoadsorption. So that is question number 1, sir. Question number 2 is whether it's 1, 2, or 3 weeks. So the day you give rituximab, you start mycophenolate mofetil at least, and maybe after a week or so you could start CNI. Although there are many guidelines which says that you could start both CNIs and MMF together and then go till the transplant. Some of them say, you give 2 weeks of MMF prior to starting plasma exchange or immunoadsorption and 1 week of tacrolimus. So the bottom line is you have an adequate therapeutic level of tacrolimus at the time of transplantation, and you have MMF which is going on in circulation for about 2 weeks. So I think 2 weeks is a reasonable time. We will also have to factor one more thing, is giving too much of tacrolimus and MMF in a patient with ESKD. Most of these patients develop diarrhea. With these patients are remaining on dialysis till they undergo transplant. So that is also a flip side to it. So we need to keep that in mind. Many of our patients do not tolerate 4 tablets of Cellcept, and we need to come down on the mycophenolate mofetil in them. And when you add CNIs, it gets complicated. So yes, 2 weeks is the answer, at least as of now.
And as you mentioned in one of the slides,
yes,
that the titer prior to transplant, that 1 in 16, this is the outcome, 1 in 16, 32 to 64, or 1 in 128. Does the titer, once you have reduced the titer prior to transplant to adequate level, 1:4 or something, does it have any implication on long-term graft outcome?
Sir, the slide that I showed was from the Japanese study which was published in 2000. Actually, the titers that I showed was just the day prior, it was just the day prior to transplant. Yeah. So they even transplanted with a titer of 1:128, and they did go on to show that 1:128, some people did well, but most of them did not do well. Only at the end of 5 years, only 29% had a surviving graft. So, once you say that, the titers, there are 2 types, opening titers, that is the titer before desensitization, that is also important. And also the titer which is prior to transplant, that is again important. In the sense that if you are having a very high opening titer of 1:256 and above, or 1:512 and above, the risk of rejection is high. And also the long-term outcome is poorer as compared to somebody who has got low opening titers. And whether the opening titer is significant or, the pre-transplant titer, which among the 2 is more, I don't think we have a scientific data to support the conclusions.
I think next question is after Professor Gupta.
Thank you, General Verma, for allowing me some time. And both the talks, as usual, were excellent, and we learned a lot from both of them. Now, starting with you, Raja, since your center does both swap transplants and ABO incompatible, if you had a patient, which one would you choose first?
Yes, so it's a very pertinent question, sir. And that is why in the slide itself, in my first slide itself, I said a KPD greater than ABO incompatible transplant. At least for 2 reasons. First one is an ABO compatible transplant with a kidney paired donation is economical as when compared to an ABO incompatible transplant. And the second point is, the outcome, long-term outcome also, we know that an ABO compatible transplant is better. Third is the infection and the other complications like chronic infections like BKV are also higher in patients who undergo an ABO incompatible transplant. So I think it is swap only, sir. We also, try to find them, but most of the times we are unable to find a transplant in a patient who is O positive. So O is the...
Very true. Yeah. Very true. Very true. So by and large, if the message that you're trying to give is that we attempt to do a swab transplant if it is feasible and possible, but there could be occasions like particularly the O group, or you have someone who is, who can't find a swab transplant. There you would perhaps go in for ABO. But the data as of now, as you and Muthu have shown, is now that the results of ABO incompatible transplants is improving over the years, particularly the Japanese data, etc. So, at what titer level, which just taking over the question from General Verma, beyond which you would say that no, I wouldn't go in for an ABO incompatible? Would you say it's 512, or would you say 1024, or would you try at any level?
It's a very good question, sir. Because this question also came to our mind when we started the program. I'm sure that it would have been there when you were there at SGPG also, sir. When a titer of initially at PGI we kept a titer of 256. So anybody above 256 we weren't actually taking them up for ABO incompatible transplants, because we for at least two reasons. One is the number of plasma exchange required in them is humongous, and that time immunoadsorption was not available freely, and these patients run into a lot of infections. If somebody has to receive 15 sessions of plasma exchange, they will have to stay for 30 days in a public sector hospital. They are coming from a general ward to a dialysis room, going back. They are likely to develop more infections. So that is why we told that about 256 we weren't taking earlier. After the introduction of immunoadsorption column, we are taking those patients. But if I remember, at least in the 40 plus transplants that we have done, there is, I think, only one patient whom we took who had a titer of 5 and 12. Otherwise, most of them were about, I think it was median would be somewhere between 64 and 128.
What would Muthu's comments be in this regard? Dr. Muthu, would you like to say anything? Would you accept someone with a higher titer as compared to 256?
Yeah, no, I think I agree with the explanation provided by Raja. I don't think we would also go more than 256. But again, as he pointed out, we are more and more resorting to swaps rather than ABO incompatible. Practically, it's last several years we haven't done any ABO incompatible transplants at all.
At us, when I was in SGPGI, we have done several of these ABO incompatible, and the highest titer we took was 1024. But I think I regretted accepting that patient, because we had to do large number of plasmapheresis sessions and also use this filter as well. Ultimately the patient had to pay a huge amount of money, and then we had some problems post-transplant. Fortunately, we were able to pull him through. But I think anything above 5, the most that we can take is a 512, on which I think should not be. General Verma, back to you.
I just wanted to ask Dr. Muthu, is the level of DSA prior to transplant, does it linearly correlate with the outcome?
No. So as I said, sir, because this is not a linear scale. In fact, we need to, let me re-emphasize that MFI is not a scale at all. It is simply a relative value without any reference. But we try to, in published papers, try to provide some rationale for these numbers and say whether can we use that. But because of this C1q binding and the fact that not all antibodies are created equal, a 10,000 MFI doesn't mean that's a bad antibody, or 1,000 MFI doesn't mean that's a good antibody, and nothing is going to happen. So it's extremely, in a large studies, it's extremely difficult to come up with some numbers and say that this is safe. And again, as I told, when we say threshold for what? The idea of these MFIs cut point were designed for surgeons. You need to do the surgery safely and come back without having a problem on the table. So if you have an MFI of a rough idea is that, at least based on our lab, when we have a 10,000 MFI, approximately around that range, our CDC will be positive. When we have around 6,000, our flow will be positive. So this gives, especially in the virtual cross-match field, where we have no time for we have no time for CDC or flow. We simply go by the existing DSA levels. Around 6,000, we will say, okay, this is probably flow positive, and then you need to make a decision that are you going ahead or are you stopping? So other than that, for an individual patient, 10,000 may be completely fine because it may not be a C1Q or it may not be a proper antibody at all. Remember that, as I told, this is all denatured, reacting against a denatured antigen. At the same time, 1,000, 1,500, we may say it is lower than our cut point, but over time, there can be a slow chronic endothelial injury which results in transplant glomerulopathy.
So how do you resolve this?
That becomes
Are you going by the type of antibodies that if
no, that's what becomes extremely challenging. In other words, when the pre-transplant DSA is 0, and then we continue to, if there is a high immunological risk like an African American or a woman or something like that, and we continue to follow, as long as the titers and as long as the MFA values continue to remain, the vast majority will have 0. Then we are fine. The moment we have some amount of DSA, in a way we don't look at the absolute MFI values. We try to do a surveillance biopsies to see what happens and catch them early. But whether this simply giving IVIG and steroids to mitigate the microvascular inflammation, is it helpful? We need larger studies because these are all sort of resistant plasma cells that produce antibodies. It is not like a one-shot cell-mediated rejection. This is sort of difficult to treat by our conventional therapy. So that's why I didn't focus on therapy, because each of us will have a favorite protocol and a favorite drug. And the bottom line is none of them are really helpful.
Can I ask one question, General Verma, if you permit me?
Please.
Just a question once again about ABO incompatible transplant. Maybe Raja can take it, or to say, can you say that if a patient who has had an ABO incompatible transplant has remained free of any graft dysfunction for, say, X number of weeks, what would be the time frame after which you would say that this fellow has had an accommodation of the graft or whatever it is? Raja,
you're muted. Raja,
Sir, it's again a wonderful question. So
maybe I can provoke you by saying that maybe somewhere around 3 to 6 months is the cutoff for that.
Sir, accommodation. However, there was one question. One of the attendees had actually asked that in that I had written, sir. So accommodation can happen very quickly, sir. It can happen within 1 to 2 weeks also.
2 weeks.
And 1 to 2 weeks itself, you can have an accommodation, and up to 75% of them can have C4D positive with respect to an ABO incompatible transplant. With respect to monitoring the ABO titers, and I think 2 weeks should be fine. There have been disputes between 1 week, 2 weeks, and 4 weeks. It's an unsettled dispute, but again, after 2 weeks, it shouldn't be of any significance. But yes, after most of these O group transplants are also HLA, a sort of HLA incompatible transplant, like you don't have 100% match in between them. So it could be very much that they could be developing anti-HLA antibodies. We had 2 patients who actually had ABO incompatible, who had rejections. And, we were thinking of it's probably related to AB, but once we did the DSA, we realized that they actually, stopped the drugs in between, and they actually had a 10,000 plus donor-specific antibodies. And the ABO titers were less, it was 1:16, but I think that should be fine. But it was actually the anti-HLA antibodies in both the patients, which was actually causing the rejection. They had chronic rejection plus an acute worsening kind of situation.
Just to Raja, the point about the infections, what you were mentioning, because all these studies what were done prior to this, that they have used significant amount of ATG. All the studies have used 6 milligram, 9 milligram of ATG. Now you have come down to just around in India 3 milligram of ATG. There is no data which is compared 3 milligram ATG. Is really the infection rate very high?
Sir,
the second question I'm asking you is...
but are we using ATG? Most often you use basiliximab, after.
It depends. There are many centers who are still using ATG. Because Previously, people were using rituximab 500 milligram. Now, basically, people have come to 200 milligram. Calcutta group is using 100 milligram, and the rituximab dose has come down. Likewise, the ATG dose has come down now because the infections, whatever were reported, they were with higher doses. I don't know with the present scenario what is the picture. And secondly, how long the C4D positivity will remain in the graft. There's a part of accommodation because why I'm saying today only, but we did a biopsy. I was just seeing the biopsy. This patient had ABO incompatible transplant 3 years back in 2018. And on the biopsy report, we found diffuse C4D staining throughout the biopsy. And it was full of neutrophils. It was more suggestive of acute pyelonephritis. But the pathologist who saw it first, he got frightened. He said, such a diffuse C4D positivity all over that please tell me, is it ABO incompatible or something? That means even after 3 years, we saw today that C4D positivity remained through and through. Your comments on these 2 points.
Sir, I will take up the 2 questions, and I would also ask Dr. Muthukumar's comment on the 2 questions. So regarding ATG and infections, sir, we are currently, our unit uses ATG as the induction agent. We scarcely use basiliximab. And recently there was an analysis done, which was done across India by one of the pharmaceutical, if I recollect, where they looked up into the infection rates with ATG. And what they found was the infection rate, even with 3 milligrams of ATG, was significantly higher as compared to patients who did not receive any sort of induction or received basiliximab induction.
I hope the trial was not by basiliximab company.
Sir, I wouldn't go into details of it, sir. Sir, the other flip side to this is many a times, although CMV prophylaxis has been recommended in all the patients who receive ATG induction at least, but it's not being followed up 100% in patients who receive ATG. So the incidence of CMV goes up. Once the incidence of CMV goes up, you have incidence of other infections going up like UTI and the tuberculosis and fungal infections, candida. So these infections also go up simultaneously. So that is one part of it. So if you're using 3 milligrams of ATG, yes, it incurs some amount. If it is doing some good with respect to the immunology part, so it should be doing some harm. If it isn't doing any harm, that means it's not working. So it's that way at least. Second one, how long does the C4D stay? It starts about 1 to 2 weeks and it's there, it's accommodated, sir. It is there forever. It's that kind of situation. Okay. So I would pass it on to Dr. Muthu for comments, so is more wiser.
Yeah, so this question of ATG, yes, there are no high quality studies comparing 3 doses versus 4 doses versus 5 doses. If I recollect, there was a 2017 paper in clinical transplantation. Yes. I think it's from Iran. They did like 90 or 100 patients where there were 3 ATG groups. One was a 4.5 milligram, 3 doses, like 1.5 milligram every day. Another one was 4.5 milligram single dose. Another one was 6 milligram per kilogram body weight, I think in 3 or 4 days. So the traditional one can say this as a single dose 4.5, 3 doses of 1.5 each and 4 doses of 1.5 each. I think the efficacy was more or less similar, meaning that the acute rejection rate was not different, but there were less complications in the 3 milligram dose compared to 4.5 milligram. So one can say that we do not know the exact dose that will prevent. So especially for low immunological risk patients, probably ATG is not needed, or if at all needed, 3 doses should be sufficient.
I think we hand over to Professor Sakhuja.
But Raja, would you use ATG as an induction in ABO incompatible at all?
Sir, our usual protocol is ATG for all the patients, and we have covered it ABO incompatible also with ATG. I do agree that the risk of infections with
because at our center we were using basiliximab.
Yes, I know, sir.
Most of the centers in India are using still ATG.
Because basiliximab does as well. I mean, since you are already giving rituximab, I don't think there is any need of giving ATG.
Yes, sir. I personally agree upon that, but it's a unit protocol,
Yeah,
and
policy,
there could be many other factors which decide upon that.
Just one brief question to Raja. Are you using IVIG or not
We are not using
in your
IVIG.
protocol?
Right from the patient one, we are not using IVIG.
You are not using it currently.
Yes.
Okay. Right. And
we
are
were-
you
we were-
using
we were using
double
it.
filtration plasma exchange
Sir,
or
to the best of my knowledge, that facility isn't available, sir.
isn't available? Yeah. Right. Okay. Are there any other questions from the participants, those who are listening into this program? Are there any last minute questions?
So there are several questions in the question and answer box. Actually, there are 5 of them.
ABO part, I've answered all of them.
Anything left that has not been answered?
Oh, sorry, I didn't see this question and answer box.
Even I haven't seen it.
Does SAB tell us about antibody, whether it is complement binding or not? Answer to
No.
that is single antigen bead alone is not.
Not,
So,
yes.
in fact, if I can extend on that, I mean, we attribute too much effect to complement, but more and more data is coming in that this transplant glomerulopathy or the chronic antibody-mediated rejection is probably a ADCC mechanism, meaning that it's an antibody-dependent cell-mediated cytotoxicity where NK cells are involved and not complement-mediated. So
Okay.
complement may not be the mechanism for everything.
Mm-hmm.
Precautions from the beginning to get rid of de novo DSA. The 2 most important things are make sure that the patient is compliant with all the medicines, not miss a single dose, and make sure that we as physicians are not reducing the immunosuppression for whatever reason. Now, that is easier said than done because you can have a bone marrow suppression, severe diarrhea, not able to tolerate. And again, over, say, X number of months after transplant, at least first few months, we are all very comfortable, but X number of months after transplant, 1 year, 2 years, what is the ideal dose? How do we monitor this? That is challenging. That's where all these molecular tools, as and when it becomes cheaper, it will be beneficial to target or personalize immunosuppression based on that. And one can use like a CD4 functional assays or your DSA titers and other things. So that's one way to monitor. So the best way to prevent de novo DSA from coming is to simply make sure that the immunosuppression is adequate. The next question is, what is the role of cell-free DNA in detecting rejection during immediate or early weeks of post-transplant? How long do cell-free DNA prevail in the blood following an episode of rejection? Will it affect diagnosing the second episode of rejection happening within a short interval from the first? Now, cell-free DNA, plasma cell-free DNA is catching up a lot. The AlloSure, which is the CareDx company, their cut point is 1%. So the donor-derived fraction is, you simply take a plasma sample, measure the free-floating total DNA there, and get if the donor-derived fraction is more than 1%, then it is considered as significant donor injury. For this, the donor HLA information or the donor genotyping is not needed. Simply, they go by an algorithm in which they are able to say that based on single nucleotide polymorphisms, what proportion of my DNA that I have in my hand is donor derived. And that's where they come up with this 1% cut point. The problem with donor derived DNA is that this is not, it is not mechanism based. Any type of injury to the organ so you cannot differentiate whether it's an AMR or an ACR or an ATN. Fortunately, it so happens that in ATN, we don't have that much of DNA release. So far they have been fine with this 1% cut point. So that's where we are. And it may be useful for monitoring, but we need more studies to say that how frequently this donor-derived DNA should be used. One more question. Standard test to order pre-transplant in a low-risk or high-risk recipient. Can you clarify that? What is meant by standard test? Dr. Sandeep Kumar Panda?
Possibly he's asking that CDC, we are doing
we
are doing
flow
should we do DSA also.
Yes.
If it is a low risk, should we go ahead with DSA also? Possibly
Yeah,
in US, 100% DSA
Yeah,
is done.
sitting in New York, unfortunately, I cannot answer that question. We do everything for all patients. So I think it should be a local institutional policy of who are your low risk people and who are your high risk people and what are you trying to do to them.
I think I'll take up that question because
Sure,
local
please.
level. So because we have had bad experience, so somebody who had a bad experience can speak better on the protocol. So we actually had a rejection rate of 25 to 30% a few years ago, 2-3 years ago. We had a rejection rate, and what we were testing in all the patients was only a CDC cross match. We were not doing anything else. And the patients who had positivity for CDC, we used to do some plasma exchange, proceed with transplant. But after that, what we believed was 30% was too much. And then we introduced flow cytometry and also DSA. DSA has been done in patients who have sensitized. Sensitized definition is pregnancy, any blood transfusion, or any history of recurrent infections, IJV, HCV infection, or any other infections. We did DSA. With incorporating flow and the DSA, we have come down from about 25 to 30% to less than 10%. So I think you should go more by your center's experience rather than just hearing to some other center and deciding upon what to be done. In somebody who is sensitized, I think you should use all your tests because it is worthy to put your money before the organ is placed. Rather than, you have put an organ, develop rejection, and then you start plasma exchange in the patients. I see it that way.
No, I fully agree with you. I think when you are trying to, in Indian scenario, when you are willing to spend 6 lakh, 8 lakhs on transplant, it is worth doing DSAs also for 20,000.
Yes.
So it is worth doing that. As a unit protocol, it should be that you are going for CDC, you are going for flow, you are going for DSA also.
If I can add on to what Raja said, that point is well taken. And especially when we say immunosuppression, sometimes we have a tendency to say that, okay, we just discussed about 3.5 milligrams and 5 milligram ATG. We focus on minimizing immunosuppression in the beginning, forgetting that when these patients develop rejection, the eventual immunosuppression that's required to pull them back will result in total immunosuppression that's probably more than what we had anticipated. So in a way, it's better to target the higher immunological risk patients initially, sort of give the maximum immunosuppression initially, and then follow them at a stable level so that they are immunologically, they are fine.
Hello.
Right. So I think we have exhaustively covered the subject. I'd like to thank both the speakers.
Professor Sakuja, can I ask you one question?
Yes. Okay.
Just a question, not related to the topic, that should we vaccinate COVID vaccine to our transplant patient?
These are life attenuated.
The recommendations of the American Society of Transplantation and the British Transplant Society. And both of them have said that the COVID vaccination should be given to transplant recipients, provided they are not suffering from any intercurrent illness at the moment. So that is the recommendation. However, the studies on the vaccine that have been done have not included any transplant recipients. That's all I have to say about that.
So if I can add on, we started, some of our transplant patients have started getting because they are either healthcare workers or teachers or something like that. So far, we had about 10. One has completed second dose, but these are all Pfizer and Moderna, not the Oxford vaccine. So far, no problems. Based on anybody's transplant patient's prior experience with immunization, I don't think excess immune response and acute rejection is going to be an issue. The issue is the efficacy, whether this is going to convert to zero convert these patients. That needs to be checked. And there again, I would like to re-emphasize that we need to be careful when we monitor the antibodies, because most of the commercially available antibodies do not target the spike protein. So we need to check with the lab when we check the SARS-CoV-2 antibody post-vaccination. We need to make sure that that's the right antibody that is supposed to happen after the spike protein antigen. Of course, maybe for Oxford vaccine, it may be different, but here they are targeting the spike protein.
Right.
Thank you very much for that answer. So once again, thanks to both the speakers and both the panelists for having done an exceptional job. And I'll end my participation simply by saying that to achieve the best results when you're doing a kidney transplant, we need to focus not too much on the immunosuppression. Not that the immunosuppression is not important, but I think as we grow wiser with more and more knowledge regarding donor specific antibodies and how to monitor them, I think it's more careful selection of the donor for a particular recipient that will ensure the best outcomes as compared to just more effective immunosuppression. So we need to uh, emphasize that aspect much more. With that, I'll hand you over to MCure for their concluding remarks.
Thank you, Sakhuja sir. In fact, I would like to thank both our speakers, Dr. Raja and Dr. Muthukumar, for the wonderful talks that were given by both of them. And also my special thanks to Dr. Amit Gupta and Dr. P.P. Verma sir for the excellent panel discussion that we had on ABO incompatible kidney transplantation and also the HLA matching type for the donors. I'm sure with this topic that we had today, which was discussed in details, many of the young nephrologists who are upcoming would greatly benefit from the advice that has been given by all of you, sir. I'm sure the total combined experience that you all share is very high, almost close to maybe 150 years, 160 years of experience in nephrology, which is being shared today. And from MQR, sir, we thank you all for sharing the dais with us, sir. And we wish everybody a very great new year. And I hope the vaccination program, which has also been started in our country, is successful and we all are safe from this COVID time, sir. Thank you very much all for your time, sir. And we hope to see you again soon.
Thank you very much indeed. Thanks a lot to